Welcome back to Radonk's Smart Review GYN series. This is a case-based review, and we're focusing on some really exam-separating scenarios in GYN oncology, things like locally advanced vulvar and vaginal cancers, sentinel node management, complex recurrences, and of course toxicity. We're going to run this as a formal oral board examination. So, are you ready to be in the hot seat?
I'm ready. Let's do it.
All right, let's start with case 1. This is a case of unresectable, locally advanced vulvar cancer. The scenario is a 68-year-old woman. She presents with a painful 7-centimeter ulcerated vulvar lesion.
Right.
It involves the clitoris, extends to the urethral meatus, and it is fixed to the pubic bone.
Fixed.
Exactly. And she has bilateral, fixed, matted inguinal nodes. Biopsy confirms squamous cell carcinoma, so this is clinically an unresectable stage 4A. Your task is to formulate and defend a neoadjuvant chemoradiation plan. Walk me through the simulation, volumes, doses, and the systemic therapy.
Okay. So I confirm the diagnosis of unresectable, locally advanced vulvar squamous cell carcinoma. My main objective for this patient is neoadjuvant concurrent chemoradiation.
And the goal there?
The goal is really twofold. First, to downstage this really bulky fixed tumor and the nodes to hopefully allow for a function-preserving resection later on.
And the second part?
And second, to provide comprehensive curative treatment to all the involved regional nodal basins.
Good. Let's start with the technical aspects. Walk me through the simulation setup. How do you ensure this is reproducible and you're minimizing skin issues?
Simulation is absolutely critical here. I'd simulate her supine, but in a frog leg position.
Why that specific position?
That position helps to flatten out the vulva and the inner thigh skin folds. It's really essential for getting a homogeneous dose and reducing those potential skin hotspots that can cause just awful acute toxicity.
What about marking?
We have to use radiopaque markers. They need to be placed very carefully along the visible margins of the tumor and the palpable boundaries of the inguinal nodes. And I would definitely use IV contrast for the planning CT scan.
And why the contrast?
It's for nodal definition. The contrast helps us clearly see the iliac and femoral vessels, which gives us the roadmap we need to accurately contour all the nodal regions.
Okay, that covers the setup. Now, define your target volumes for me, GTV and CTV. And I want you to defend your decision on including the pelvic nodes.
Certainly. So the GTV primary is the entire gross vulvar tumor that we see clinically and on imaging. The GTV nodes would be that fixed, matted, gross inguinofemoral disease.
Yeah, CTVs.
The CTVs have to cover both the primary and the microscopic risk areas. So the CTV primary is the GTV plus a margin, and this would encompass the entire vulva, the perineum, all the way down to the inferior border of the ischia.
And the nodal CTV, you mentioned the pelvic nodes. Justify that.
Right. Given how advanced her disease is, bulky, bilateral, fixed groin nodes, the risk of microscopic spread up the chain is just too high. So the nodal CTV has to be extensive. It must include the inguinofemoral nodes and the pelvic nodal basins. The pelvic coverage would specifically include the external iliac, internal iliac, and the obturator chains.
And your technique for delivering this complex field?
Oh, this has to be highly conformal. I'd use IMRT or VMAT. That conformality is really the only way to safely treat these targets while aggressively sparing the femoral heads, the bowel, and the bladder.
A very comprehensive rationale. Now let's talk dose. What's your prescription for the gross disease versus the elective volumes?
I'd use a simultaneous integrated boost and SIB approach to deliver 2 dose levels at the same time. For the gross disease, so the primary vulvar tumor and those involved nodes, I'd treat to 54 gray in 1.8 gray fractions.
And the elective volumes?
The elective nodal CTVs, which are the uninvolved pelvic nodes and the rest of the groin, would get a standard prophylactic dose of 45 gray in 25 fractions, also in 1.8 gray per fraction.
Good. And what systemic therapy are you using concurrently, and what's the basis for that choice?
The standard of care is concurrent chemo here. So my standard regimen would be weekly cisplatin at 40 milligrams per meter squared.
And your reasoning?
Well, this is extrapolated from proven success in advanced cervical and anal cancers, where adding weekly cisplatin to radiation improves local control and survival. Of course, if she had contraindications, like poor renal function, I'd discuss alternatives with medical oncology, but cisplatin is the gold standard.
All right. Treatment's done. What's the next step, and what's the timing?
We need to wait for the full biological effect to kick in, so I would schedule a definitive restaging exam, both clinical and with imaging, about 6 to 8 weeks after chemoradiation is complete.
Excellent. And that's the key principle. For unresectable vulvar cancer, You downstage the chemorad, then reassess for surgery. Your plan was very well articulated. Now for the twist in the case. After your chemoradiation, her groin nodes regress very nicely. They're no longer fixed. But the primary vulvar lesion remains fixed to the pubic bone. The surgeons still deem it unresectable, and she declines an exenerative resection. How do you manage this residual unresectable disease?
Okay. This completely shifts my goal. She's refused the only surgical option left, so the focus now must be on definitive, non-operative local control. And that means I have to dose escalate significantly to the residual tumor.
How do you do that?
My immediate recommendation would be to proceed with an interstitial vulvar brachytherapy boost.
Okay, detail the technique in prescription for me.
Oh.
How are you managing the cumulative dose?
Right. The interstitial technique is key here because the tumor is deep and fixed. A surface applicator just won't work. So under anesthesia, I'd use a perineal template, something like a Syed-Neblet or MEPIT template, to guide the placement of interstitial catheters.
And the goal of those catheters?
The goal is to place them in multiple planes to completely bracket the residual tumor plus, a 5 to 10 millimeter margin. After the implant, we'd get a CT or an MRI for 3D planning. And the prescription would be an additional 16 to 20 gray, delivered in 4 to 5 twice-daily fractions.
What's your ultimate dosimetric goal? What cumulative dose are you trying to achieve?
The overall goal is to bring the cumulative EQD to the equivalent dose in 2 gray fractions to that primary tumor into the 70 to 74 gray range. That's the dose level we know improves local control for these bulky tumors. And of course, during planning, we'd have very strict constraints on the rectum, bladder, and urethra to prevent things like fistula.
That is the perfect board's critical response. When you have unresectable residual vulvar disease after chemorad, the move is the interstitial brachytherapy boost. You have to frame it as a highly conformal escalation to that 70 to 74 gray EQD2 range. Okay, let's move to case 2, primary vaginal cancer. Here's the scenario. A 70-year-old woman with a 3-centimeter squamous cell carcinoma in the lower third of the posterior vaginal wall.
Okay, lower third.
A PET CT is negative for any nodal or distant disease. You are planning definitive chemoradiation. The question is simple. Which nodal basins must be included electively, and why, given the specific tumor location?
Okay, to answer that, we have to talk about the lymphatic drainage of the vagina, which is very segmental.
Please review that anatomy for me.
So the upper 2/3 of the vagina drains superiorly, basically just like the cervix. It goes primarily to the pelvic nodes obturator, internal and external iliacs. But the lower third, which is where this tumor is, drains inferiorly. It's more like the vulva. It drains to the inguinofemoral nodes. So because her tumor is in the lower third, my elective nodal CTV has to cover both pathways. It must include the pelvic nodes, A and D, the bilateral inguinofemoral nodes.
And why is that mandatory, even with a negative PET scan?
Even though the PET is negative, the lower third's first echelon drainage is the inguinal nodes. If we omit them, we're looking at maybe a 15 to 20% risk of an isolated groin recurrence. So the CTV has to include the pelvic chains, external iliac, internal iliac obturator, and the bilateral superficial and deep inguinofemoral nodes.
Good. And your technique?
For that kind of field pelvis plus bilateral groins, it really has to be IMRT or VMAT. It's the only way to shape the dose properly while sparing the bow and femoral heads.
Excellent. The teaching pearl is simple. Upper 2/3 equals pelvic nodes. Lower third equals pelvic plus inguinofemoral nodes. You tied the anatomy perfectly to the field design. But now for the twist. After 45 gray of chemorad, your exam shows a bulky 2.5 centimeter thick residual tumor on that posterior wall. A simple intracavitary cylinder will underdose the depth. Design your brachytherapy boost.
Right, a 2.5 centimeter deep residual. That is far too thick for a cylinder. You're right, that would be an underdose. This absolutely requires image-guided interstitial brachytherapy.
So what's the plan?
The plan is a full interstitial implant. In the operating room, under anesthesia, I'd place a perineal template, again, something like a Syed-Neblet or MUPIT.
And how do you ensure your needles are placed accurately relative to that deep tumor?
Accuracy is everything. I'd use transrectal ultrasound guidance during the needle insertion. This lets me see in real time where the needles are going to make sure we bracket the full thickness of that residual tumor plus a 5 to 10 millimeter margin.
And after the implant?
After the implant, we get a CT or an MRI for 3D planning. The dose goal is to achieve a cumulative EQD2 of around 75 to 85 gray to the high-risk CTV. And through all of this, the priority is minimizing hot spots to the rectum and bladder, sticking to those D2CC constraints to prevent fistulas.
Excellent. And that is the key takeaway here. Any residual tumor that's more than a centimeter thick in the vagina or cervix after external beam should always trigger the phrase interstitial, not intracavitary, brachytherapy. Let's move to case 3, adjuvant vulvar cancer. This is about sentinel node management. Scenario: a 3-centimeter T1b vulvar squamous cell carcinoma, clinically node negative. She has a wide local excision plus bilateral sentinel node biopsy. Margins are clear. One right sentinel node contains a 3-millimeter metastasis with no extracapsular extension.
Okay.
How do you manage her groin, and what's the evidence supporting your plan?
Okay, first step is risk stratification. A 3-millimeter deposit is, by definition, a macrometastasis. That's anything greater than 2 millimeters.
So given that it's a macrometastasis, what is the standard of care?
The standard of care for macrometastatic sentinel node disease is a completion inguinofemoral lymphadenectomy, or IFL, on the involved side. In this case, the right side.
And your overall adjuvant plan?
That would depend on the final pathology from that completion dissection. If, for example, she had 2 or more positive nodes found, I'd recommend adjuvant radiation to the right groin and possibly the ipsilateral pelvic nodes to about 50 gray.
You mentioned radiation alone is sometimes an option. Why is dissection still required for a 3-millimeter deposit? What's the evidence?
The evidence comes from the groin's V-Logic trial. That trial showed that radiation therapy alone is a safe alternative to dissection only for micrometastases, which are defined as 2 millimeters or less.
And for macrometastases?
For macrometastases like this one, leaving the groin undissected and just treating with radiation carries an unacceptably high risk of groin recurrence. So, surgery, the completion IFL, remains the standard to clear the basin first.
That's the critical nuance. You have to tie the decision to groin's V. Less than or equal to 2 millimeters, radiation is an option. Greater than 2 millimeters, you need the completion dissection. Now for the twist. Same patient, same 3-millimeter metastasis, but the pathology report now clearly states there's extracapsular extension, ECE.
Oh, okay.
How does this ECE finding modify your adjuvant plan?
ECE is a major adverse feature. It means the tumor has breached the lymph node capsule. This signifies a much, much higher risk of both regional failure and, importantly, distant failure.
So what's the plan?
For surgery, she still needs that right completion IFL. For radiation, I would now strongly and definitively recommend adjuvant radiation to the right groin and the ipsilateral pelvic nodes to about 50 gray.
And the biggest change?
The biggest modification is the systemic approach. Because of the high risk associated with ECE, I would seriously consider concurrent weekly cisplatin during radiation. And on top of that, I would have a serious talk with medical oncology about full-dose systemic chemotherapy to address that increased risk of distant relapse.
Perfect. When the examiner says ECE, your reflex should be to escalate both local and systemic therapy. That's exactly right.
Yeah.
Case 4, salvage re-irradiation. A 60-year-old woman, 3 years out from definitive chemorad for stage 2B cervical cancer. She received about 85 gray EQD2 to the cervix. Now she has a 2-centimeter isolated vaginal apex nodule. It's a biopsy-proven recurrence, no other disease. She's not a surgical candidate. Is she a candidate for salvage re-irradiation? And how do you reason through that?
Okay, this is a classic re-irradiation question. I'd approach it by looking at 3 domains: disease factors, patient factors, and prior treatment factors.
Walk me through them.
First, disease factors. They're actually very favorable here. She has a long 3-year disease-free interval. The recurrence is small and isolated. These things suggest a good chance of achieving local control. Second, patient factors. She needs to have a good performance status to tolerate this. Assuming she's medically fit, we can consider it. Third, prior treatment factors. This is the big constraint. She's had a full curative dose to the pelvis, so her rectum and bladder are dose limited. But because the recurrence is so small and focal, we could potentially target it with something highly conformal, like SBRT.
So what's your conclusion, and how do you consent her?
Based on the positive disease factors, I'd say she's a reasonable candidate for salvage re-irradiation with curative intent. But the consent process has to be incredibly detailed. I would have to tell her that while we have a good shot at controlling the tumor, she faces a significant risk of grade 3 or 4 late toxicity, including fistula.
How high a risk?
Potentially in the 15 to 20% range, maybe even higher. She has to understand and accept those life-altering risks before we proceed.
That is the structured answer we look for. Disease factors, patient factors, prior radiation factors.
Excellent. Now for the twist. She consents. You decide on SBRT re-irradiation. Outline a safe SBRT plan for me. Dose, fractionation, and how you handled the cumulative rectum and bladder dose.
I'd plan a highly conformal SPRT regimen. The dose would typically be 30 to 35 gray in 5 fractions delivered every other day, but the core of the safety strategy is managing the cumulative limits. It's a 3-step process.
Go on.
Step 1 is retrieving the data. I have to get her prior plans and convert the old rectal and bladder D2CC into an EQD2 to know her baseline lifetime exposure. Step 2 is setting the limits. I'd aim to keep the total cumulative rectum D2CC under about 90 gray EQD2 and the bladder under about 100 gray EQD2. Step 3 is optimization. This is where the trade-offs happen. I'd use very tight PTV margins, and most importantly, I would prioritize the OAR constraints over full target coverage.
What does that mean, practically? It means I'm willing to accept a planned, modest undercoverage of the PTV if it's necessary to protect the rectum or bladder. Safety comes first.
That is a critical safety concept. You have to say, I prioritize cumulative OAR dose over perfect target coverage. It shows you understand the gravity of the situation. Case 5, acute toxicity management. It's week 4 of definitive pelvic chemorad for cervical cancer. Your patient reports 10 watery stools a day, cramping, and lightheadedness.
Okay.
Her labs show an absolute neutrophil count, or ANC, of 800. Walk me through your management steps.
This is a red flag. Grade 3 diarrhea and grade 3 neutropenia during concurrent chemorad. This is an urgent situation. First, immediate action. I tell her to come in immediately. We have to hold both radiation and chemotherapy right now while we stabilize her.
Okay, she's in your clinic. Detail your workup in supportive care.
For the workup, I'd get vitals, check for orthostatics, do a physical exam. Labs need to include a BMP, magnesium, and definitely stool studies, including for C. diff. Supportive care would be immediate IV fluids and electrolyte repletion. I'd start high-dose loperamide and put her on a low-residue diet. For the neutropenia, neutropenic precautions, and I'd consider GCSF to help her marrow recover.
When can you resume treatment? What are your criteria?
We cannot resume radiation until her diarrhea is down to grade 1 or less. Her ANC has recovered to over 1,000. And given the severity of this, I would permanently discontinue any further concurrent cisplatin. The priority now is to finish the radiation and brachytherapy without any more interruptions.
Correct. The reflex for grade 3 or higher toxicity is hold everything, stabilize, then cautiously resume radiation alone. Good. Now the twist. A week later, her diarrhea is resolved. Her ANC is 1,400, so that's safe. But her platelet count is now 70,000. What do you do?
Platelets of 70,000 is grade 2 thrombocytopenia. It needs monitoring, but it's not immediately life-threatening. My absolute priority is to resume external beam radiation immediately to avoid prolonging the overall treatment time.
And the chemotherapy.
I would absolutely not resume cisplatin. The risk of more myelosuppression is too high. We need to get her through radiation and brachytherapy. I'll monitor her counts closely, but radiation can proceed safely at this platelet level as long as she's not bleeding.
That's what we want to hear. Moderate thrombocytopenia is not a reason to stop curative radiation. You're protecting the dose intensity of the radiation. Case 6, oligometastatic endometrial cancer. A 70-year-old woman is 3 years out from her hysterectomy and adjuvant pelvic radiation. Surveillance CT shows a solitary 2-centimeter para-aortic lymph node at L3. It's a biopsy-proven recurrence, no other disease.
Okay.
Medical oncology proposes palliative systemic therapy alone. Defend adding SBRT to her management.
This is a classic oligometastatic state. Single site of disease, long disease-free interval. I would strongly advocate for adding local ablative therapy, specifically SBRT.
Explain the benefit. Why not just systemic therapy?
SBRT offers extremely high rates of local control for these isolated recurrences, often over 90%. By eradicating all known macroscopic disease, we aim to prolong her disease control, delay progression, and potentially even improve her overall survival compared to systemic therapy alone. So my recommendation is SBRT to the node combined with systemic therapy. This is a combined modality, not a purely palliative strategy.
You must use that phrase, oligometastatic state local ablation plus systemic therapy. Okay, the twist. On simulation, that 2-centimeter para-aortic node is directly abutting the duodenum. How does this affect your SBRT plan?
Oof. The duodenum is a serial dose-limiting organ, and injury there can be catastrophic. Its constraint is absolute.
So detail your constraints and optimization strategy.
Okay, step 1 is setting a hard constraint. I'd aim to keep the D 0.5 cc of the duodenum less than or equal to about 30 to 32 gray in 5 fractions. The max point dose also has to be within limits. Step 2, dose adjustment. To meet that constraint, I might have to de-escalate the prescription from, say, 35 gray in 5 down to 25 or 27.5 gray in 5. Step 3 is optimization. I would intentionally pull the hot spot away from the bowel, concentrating the highest dose in the part of the node that's furthest away from the duodenum.
And counseling.
I'd counsel the patient explicitly that we are prioritizing bowel safety over delivering the absolute maximum dose to the tumor.
That's the key clinical judgment. You have to articulate that you will sacrifice PTV dose to protect the duodenum. Case 7. Advanced vaginal cancer with a complication. A 75-year-old woman has a 5-centimeter ulcerating mass in the upper vagina involving the cervix. MRI shows parametrial extension, but no pelvic sidewall involvement. So essentially a stage 2B by cervical criteria.
Exactly.
How do you manage her?
Right. For advanced upper vaginal cancer with parametrial involvement, we manage it analogously to locally advanced cervical cancer. So my plan would be definitive chemoradiation.
Outline that plan.
Okay, the EBRT would be whole pelvis IMRT to 45 gray, covering the mass, cervix, uterus, parametria, and pelvic nodes. Systemic therapy would be concurrent weekly cisplatin. And for the brachytherapy boost, given the initial 5-centimeter size, I'd plan from the start for image-guided interstitial brachytherapy, probably a hybrid approach. The dose goal is to get the cumulative EQD2 to about 75 to 85 gray to the high-risk CTV, while respecting the bladder and rectum constraints.
Exactly. Advanced vaginal cancer with parametrial involvement is managed just like advanced cervix. Now the twist. She has a pacemaker, so you do a CT-based interstitial implant. 48 hours later, she spikes a fever, and imaging shows a small pelvic abscess right next to one of the needles. How do you manage this?
A pelvic abscess with hardware in place is an emergency. It's a huge sepsis risk. My management follows a strict hierarchy. Step 1, immediate halt. Hold all radiation immediately. Step 2, infection control. Start broad-spectrum IV antibiotics and get an infectious disease consult. Step 3, drainage and removal. I'd consult IR or GYN for abscess drainage. And critically, the entire interstitial implant must be removed immediately. It's a foreign body and a nidus for infection. And step 4 is the salvage plan. Once the infection is completely resolved, which could take weeks, we reevaluate for a new implant and a revised plan.
That hierarchy is absolute. Hold radiation, treat the infection, remove the hardware, then replan. Safety and sepsis trump dose and schedule every time. Okay, final case. Case 8, high-risk endometrial cancer, stage 3C2. A 68-year-old with grade 3 endometrioid adenocarcinoma. At surgery, she's found to have a positive periaortic lymph node. Final stage is T1A, N2A, stage 3C2. What's your standard adjuvant therapy?
Stage 3C2 endometrial cancer requires combined systemic and radiation therapy. It's mandatory.
Detail the plan for me, including sequencing options.
The systemic therapy is 6 cycles of carboplatin and paclitaxel. That's the cornerstone for distant disease. It can be given before, after, or sandwiched around the radiation. The radiation therapy must be extended field radiation therapy, or EFRT, because we have to cover the para-aortic nodes. The field goes up to about T12L1. Dose is typically 45 to 50.4 gray. And on top of that, we add a vaginal cuff brachytherapy boost to reduce the risk of vaginal recurrence.
And concurrent chemo.
If you use it, it would be low-dose weekly cisplatin for sensitization, but the main systemic benefit comes from the full-dose carbotaxol.
That's the strategy. Chemo plus extended field RT plus cuff boost. Yeah. Now for the final twist. During week 3 of her extended field chemo-rad, using weekly cisplatin, she developed severe nausea and vomiting, and her creatinine jumps from 0.8 to 1.5. How do you manage this?
This sounds like cisplatin-related acute kidney injury, made worse by dehydration. Immediate action. Hold both cisplatin and radiation and admit her for evaluation and hydration. For supportive care, aggressive IV fluids, multi-agent antiemetics, and electrolyte repletion. We have to monitor her renal function daily.
And the plan for resuming treatment?
The priority is finishing the radiation. Once her creatinine is back toward baseline and her symptoms are controlled, we resume radiation alone as quickly as possible. And I would permanently discontinue the concurrent cisplatin. The risk of further kidney injury is too high. She would then get her planned full-dose adjuvant carbotaxol later, with doses adjusted for her recovered kidney function.
Perfect. If cisplatin causes kidney injury, the mandate is clear. Stop cisplatin, fix the kidneys, and finish radiation therapy alone. That concludes our intensive case review. We've navigated 8 very complex GYN oncology scenarios.
It really shows that a structured, evidence-based approach is key for these complex presentations.
So let's just quickly summarize the key teaching pearls from today. Pearl number 1, for vulvar cancer. Know when to use that interstitial brachytherapy boost to push the cumulative EQD2 into the 70 to 74 gray range.
And that really underscores the need for interstitial implants for any residual disease deeper than 1 centimeter.
Pearl 2, for vaginal cancer. Master the nodal drainage rule, upper 2/3 pelvic nodes, lower third pelvic plus inguinal. Pearl 3, for sentinel nodes. Know the difference between micro and macro metastases. And if ECE is present, you must escalate both local and systemic therapy.
Right, ECE turns a local problem into a systemic one.
Pearl 4, for re-irradiation SBRT safety first, I prioritize cumulative OAR dose over perfect target coverage. Pearl 5, for acute toxicity. Grade 3 or higher, you hold everything, stabilize, and resume radiation alone.
You have to protect the radiation schedule.
Pearl 6, for oligometastatic disease. It's the oligometastatic state-local ablation plus systemic therapy, and you always sacrifice PTV dose to protect the duodenum. Pearl 7, for brachytherapy complications like an abscess. Hold RT, treat the infection, remove the hardware, then replan. And finally, Pearl 8, for high-risk stage 3C endometrial cancer. Chemo plus extended field RT plus cuff boost. And if the kidneys take a hit from cisplatin, you stop the cisplatin and finish the radiation.
A structured approach is really what translates knowledge into safe and effective clinical practice.
That wraps our GYN case-based review. Great work in the hot seat today.
Thank you. That was an excellent review.
You can find show notes and complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next series on breast radiation oncology. Thanks for tuning in.